This lecture is going to be on syncope, and we're going to follow a little bit about what Ken was talking about. Because a lot of times, you really can't tell the difference between syncope, a mild stroke, TIA, and whatnot. And one of the issues that really faces emergency physicians and primary care physicians, as well as any of the clinicians that work in the emergency department, the APPs, the PAs, and the nurse practitioners, all the clinicians wind up with this problem, which is, Mr. Jones shows up, and at some point prior to him showing up in the ED, he was laying on the ground somewhere. And as a result, he's called syncope. Did you pass out? I don't know. Were you completely unconscious? I could kind of hear people, but they sounded distant. Well, it's not syncope. Is that near syncope? Is he drunk? It's kind of hard to tell sometimes. So what we're going to talk about is an emergency department approach to syncope. And the first article actually talks about what was a very controversial study that got published back in 2016, but it caused all kinds of mayhem in the emergency department. And this was the Padroni study, which said, you know what, people who pass out, people who have syncope, tend to have a lot of pulmonary emboli, and that everybody who has a syncopal episode needs to get worked up for pulmonary embolism. So if you look at the data in that, it's an Italian research group, prospective observational study at 11 hospitals. A lot of people, 2,500 patients were there, and they divided them into low, moderate, and high risk. The lower moderate risk got a CTA, and if they were pure low risk, they just got a D-dimer to screen them. 97 people had a pulmonary embolism, but here's the problem with it. When they go through all the numbers, they say, okay, 17% of the people, once you excluded the people with cancer and those kind of things, were diagnosed with a pulmonary embolism in addition to their syncope. And so they came up with the idea that, okay, about 6%, or 1 in 6 people with a syncopal episode will have a pulmonary embolism. Therefore, we should be testing all these people. Now, there's a lot of problems with this study, and one of the problems was the following. Among the people with pulmonary emboli, 45% of them were tachypnic. So if you come in and you passed out and you're breathing at 40 times a minute, that doesn't mean you're exactly asymptomatic. 33% were tachycardic and 36% were hypotensive. Okay, that's a kind of an important clinical finding if you pass out. And 40% had signs of a DVT. So if you brought in this patient who he's tachypnic, he's tachycardic, he's got one big swollen leg after he just got his cast taken off a week ago, and he has a syncopal episode, well, yeah, no wonder he had pulmonary embolism. If you exclude all the people that we would have diagnosed with PE from that group, it doesn't come out that 1 out of 6 people has a pulmonary embolism. So this caused a whole lot of disruption in the emergency departments, and a number of subsequent studies came out. And the next 2 of them are just some of these. The next one is a Canadian study. They enrolled 9,000 people, okay? And there was 11 EDs in the United States and Canada. And what they found was that most of these people didn't have clinical signs of a pulmonary embolism, but 6% of them underwent a workup for a pulmonary embolism, and out of these, 10% actually turned out to have a PE. So that's a 0.6%. And most of these people were found, it was obvious during their presentation to the emergency department. These weren't subtle PEs. And what they did is they broke it down into subgroups. Were you older than 60? Were you younger than 60? Male, female, pre-existing conditions, and everything else. And what they found when everything was said and done was that the incidence of pulmonary embolism was less than 1%. So this idea that 1 out of 6 people has a PE just didn't hold up with this group of people. And then they followed them out for 30 days, which is usually, if you look, when you want to follow people out, if you cardiovert somebody from pulmonary for atrial fibrillation, and you want to know whether you gave them a stroke or not, you follow them for 30 days. If you stick a stent in somebody's coronary artery, and you want to see if you're going to clot it off, you follow them for 30 days. Everything seems to be 30 days. So they followed these people for 30 days. And what they found was that at the end of 30 days, the number still stuck. It was less than 1%. So their conclusion was, unless you are living in Rome, you don't have the risk of a pulmonary embolism from when you have a syncopal episode. The next paper is Journal of the American College of Cardiology, same thing. Multinational center, 7 years tracking PEs among 1,380 patients. And what they found was the PE was detected in the emergency department in 1.4%. And a pulmonary embolism or cardiovascular death occurred in up to 0.9% after they were discharged. So what they also found was if you hospitalized them, the incidence of PE went all the way up to 2.3%. So again, it's not something that we need to reflexively work up in somebody who comes in with a syncopal episode. The next article, or next abstract, looks at the trends in syncope workups. And just real quickly, what this did is it followed who's doing what study and what's happening to the patients. And it found that something kind of interesting. What it was that admissions for syncope dropped 12%, but testing for syncope went up dramatically. So advanced neuroimaging went up 3.2%, cardiac testing went up 3.7%. But in the end, even though we tested a lot more people and admitted less people for it, the actual incidence of adverse events in people with syncopal episodes stayed about the same. So, and you see this all throughout medicine. We do a whole lot more testing, but the number of cases of people dying from the same disease just doesn't seem to change. With the exception of screening for cancer, where you see dramatic changes, in the cardiovascular realm, we just don't see it. And you're going to see this come back in a couple later talks when we talk about chest pain patients as well. Abstract number 5 is a propensity score matching study. And what the propensity score means is you have a bunch of people who have disease X, and you want to know if this intervention changed anything in those people. So what you do is you go back into your medical records and you find another matching group of people who have the same age, the same gender, whatever it is you're looking for, and you match them up. And then you say, okay, did my intervention change anything? And what they did was they looked at syncope data from 11 hospitals, and they looked at discharged versus admitted patients. And what they found was the primary outcome was an adverse event at 30 days, death, arrhythmia, PE, those types of things. And what they found was these serious adverse events, SAEs, occurred in about 5%, 4.9% of the admitted patients versus 2.8% of the discharged patients. So if you do the statistics, that turned out to be statistically not significant. Seems like a pretty big difference not to be significant, 2%, but this is what they came out with. The 30-day mortality was the same for both, less than 1% in both cohorts. So they came to the conclusion it doesn't matter if you hospitalize them or discharge them, the people who are going to die are going to die, the people who are going to have an adverse serious event are going to have an adverse serious event. Kind of doesn't make any sense to me because there's always something, there's a difference between who you discharge and who you admit. You know, the person who gives blood and passes out after they gave blood, that person probably goes home. They're young and healthy and they donated blood. The person who out of the blue was cooking eggs that morning and the next thing you knew they were on the floor, that person gets admitted. So there is a difference between who we admit and who we discharge. Interesting thing. I get off the plane, we fly in yesterday, and I'm walking towards where you get the rental cars, and I'm wearing my mask and everything else, and this guy is on the little walkway there that's moving, and he goes, hey doc. I'm like, oh, God, there's somebody in Phoenix. We've all had the thing, you go to the supermarket and somebody says, hey doc, remember me? Like, you never remember them, but you always lie. It's like, oh yeah, I remember you, how you feeling? So I said, yeah, he goes, you don't remember me? It's like, you're damn right I don't. He goes, 2 days ago, I was working a couple of days ago, he goes, I'm the guy who passed out after he gave blood. I'm like, oh, I didn't recognize you, you're standing up. So, so we got to talking and everything else, and I'm like, what are the odds that you fly to Phoenix, you're wearing a mask, and some guy who was a little stunad when he came in because he was a little bit out of it because he had just passed out, is going to recognize you? Which just goes to show you, don't piss anybody off because they won't be able to find you if they're really mad at you. All right, abstract 6, totally different outcome. These guys did the same thing, propensity matching, admitting versus discharged. 11 hospitals, 8,000 syncope patients, 68% were low or medium risk by the Canadian decision aid, and we're going to talk about that in a minute. Anyway, serious adverse events occurred in 20% of the admitted patients and 4.9% of discharged patients. That's probably more common with what we see in our own populations there. The differences between the two groups became more pronounced as you added up all the different comorbidities that they could go with. Potentially fatal arrhythmias and deaths were the same, though, 26% versus 1.8%. It was not statistically significant, which is kind of scary, which means if I admit you because I'm afraid you had, a transient, pulseless V-tach that you came out of spontaneously, I'm going to find it if I admit you or I discharge you, which makes you a little bit more scared to send people home. Anyway, what they found, though, was people who get admitted tend to be more sick and tend to have more serious adverse events. This next study is actually a really nice study. I like this one a lot. What they said was, okay, what are we worried about the most with syncope? Vasovagal event, not too worried about it. You're my age and you stood up in the middle of the night to go to the bathroom and you passed out, not so worried about it. That's micturition syncope. You know, those kind of things. You went and visited your grandmother in the ICU and you passed out. We've all get those patients, right? They all come down to see the emergency department. We always worry about what? Arrhythmia. Did you have a lethal arrhythmia, V-tach? Probably didn't have V-fib because you came out of it. Or did you have some crazy atrial arrhythmia? So what they said was, the only way you're going to pick that up, unless somebody's got a loop recorder or some type of monitor on, or they've got a smartwatch or a Fitbit or something like that on, because you can go back and interrogate that, and we've done that. We've gone back and said, let me see your phone. You look at the phone and said, oh, look at that. You went into, your heart rate went up to 180. You had an arrhythmia of some type. But at any rate, the only way to do that is put them in the hospital. You put them in the hospital and you monitor them, right? The question is, how long do you monitor them? 6 hours enough? 12 hours enough? 24 hours too much? So what they did was they looked at people who had syncope and they looked at their charts, and what they found was that 31 of them had arrhythmias, 18 were bradyarrhythmias. We've seen that, they're probably vasovagal. 12 were tachyarrhythmias, one was documented V-tach, and one had a sick sinus syndrome. And what they found was the following. If you monitored them for less than 6 hours, your sensitivity was 7%. Not so hot. If you monitored them for 6 to 12 hours, your sensitivity was 29%. Better, but not great. But if you monitored them for 12 to 24 hours, it went up to 89%. So what it tells you is you really can't just watch somebody for a couple hours in the ED and send them home. You got to put them in the hospital. You got to watch them for about 24 hours to get any value out of it. Or make sure we don't go over it, otherwise I get yelled at. Let's see. So far, if you look at what seems to work, it seems that only monitoring people for an extended period of time looked at, said this is what's going to make a difference in terms of who you're going to pick up and who you're not going to pick up. All right. What about malpractice risks? Everybody knows the following. You miss a case, whether you get sued for it or not, you are way more cautious the next time somebody comes in with the same symptoms. You miss an appendicitis, somebody who had obvious gastroenteritis, and the next day you find out that they came back and had appendicitis. Well, the next guy that comes in with food poisoning, you wind up doing a CAT scan on him because you're gun shy. Okay, so the question was, are people more gun shy if they've had malpractice claims? And what they found was, yeah, in fact, if you are, for every 1% increase, or 1 per 100,000 increase in malpractice claims, there is a 7.7% increase in admissions for low-risk syncope. So if you got sued for anything, and somebody came in with syncope, you're 7% more likely to admit that patient to the hospital. And that kind of makes sense. I mean, and the bottom line is no matter how much you tell somebody or someone tells you, listen, it's not your fault, don't worry about it, you didn't miss anything, those things happen, you're still gun shy and you're still overcautious in the next patient you see. All right, one of the problems that comes up with syncope is there's no good decision rule. There's the San Francisco syncope rule. There's a bunch of rules out there. And the reason it doesn't work for syncope like it works for chest pain, like chest pain you have the heart score and a bunch of other scores, but it doesn't work for syncope is the following. Syncope is not a clear-cut disease. You can't take a syncopal patient to the cath lab and see an 80% blockage in a coronary artery. You can't do troponins on them. You can't do a lot of the stuff that you can do for these other decision rules. You can't take an x-ray of the ankle and say, oh, look at this decision rule worked great, whether they have a fracture or not. So that's the biggest problem for it. It's a non-specific disease. It's a symptom. It's not a disease. And then our goal is to find the disease that caused that symptom. So it makes it very, very difficult. One of the things is that the Canadian Risk Syncope Score, and there's a table with it on there. And we'll look at the score in a second, but the goal is if you get a score of -1 or 0, so this is one of the scoring systems where you can add stuff or subtract stuff. So if you have if you have certain symptoms, you get a +2, a +1. If you came in V-tach, you get a +12. But you can also get minus stuff. So it's clearly vasovagal. You're the guy who donated blood and passed out after he donated the blood. That's, you get a minus for that. If you look at it, the problem is the following. Look at the scoring system. It's on that table there. The only thing you can get a negative number for is a predisposition to vasovagal symptoms, and I'm not sure what a predisposition is, and vasovagal syncope gives you a -2. Everything else is a plus, and you have to get a 0 or a -1 in order to be able to be considered low risk. If you look at the sensitivity for a serious adverse event, it's 98% and specificity is 44% at a threshold of -1, and it's 96% and 58% at a threshold of 0. It's very, very difficult to get those numbers. It's just real, I mean, just about anything else you get gives you a positive number. If your blood pressure is less than 90, well, most people who are vasovagal, their blood pressure is less than 90. So you get a -1 because you were vasovagal, predisposing vasovagal symptoms, and then a +2 because you were hypotensive. So it's very, very difficult to apply the rule. Abstract number 10 said, yeah, we think it is pretty difficult to apply that rule. Let's go ahead and see what happens when we try and apply it. And what they did is they applied the rule, and they found that adverse events occurred in 6.7% of the low-risk patients, and that's not so hot, and a sensitivity of 70%. And what they really found, which was kind of interesting, is they said, if you throw the rule out and you just ask the doc, hey, doc, what do you think? And this happens all the time. The docs are 95% accurate. They're 95% sensitive. So all of these rules and the heart score and all the rest of them, anytime you throw in clinical suspicion from either the doc, the nurse practitioner, the PA, whoever, it turns out that that trumps any of the scoring systems. Number 11 looks a little bit of a balance with the Canadian syncope risk scoring system. And if they use the sensitivity of 0, or a score of 0, they got a sensitivity of about 71%, which isn't great. Specificity is 73%. That still means you're going to miss 30% of the people. So it's a nice scoring system, but it's not there. Number 12 is a great article. It said, look, we're going to compare all these scoring systems. They looked at the Canadian scoring system, San Francisco scoring system, and we're going to compare it to the CHADS-2 score. So the CHADS-2 score is a score that you look at for the people with atrial fibrillation, whether they have certain risk factors and whether you're going to anticoagulate them or not. And what they found was the CHADS-2 VAS score actually outperformed all of the scoring systems. No score or rule statistically improved on the performance of the physician judgment when they used the CHADS-2 scoring system. There's an abstract that's not in the chapter you're looking at, but it's in chapter 29 when we look at the various review articles. And what it looked at was, it again looked at the Canadian scoring system. And what they said was, if you want to discuss this with the patients, you can't just go to them and say, here's your score, you have a 0. That means you have a 30% chance of this, a 90% chance of having nothing. They don't understand it. And what they said is you really need to give them a picture to be able to look at it. And that's exactly what the last abstract looks at. The last abstract said, if you want to talk seriously with people about scoring systems, and in particular the Canadian scoring system, if you sit down with them and you say, you know, if you have an elevated troponin, you have a 99% chance of having a heart attack, they kind of don't quite get it. You have to put it in terms of what's 99% mean. But if you look at that on abstract number 13, there's that picture there. And it's a picture of all these people. And this was done actually, Amal Matou did this in Maryland. He's the first one to do it with the heart score. And he said, okay, these are all the pictures of the people. You're the dark one. You're the dark contrast of the silhouette. And what you find there is these are the chances of you having something bad if I send you home. Do you want to take this risk? And when you put it that way, when you phrase it for them in that respect, it becomes a whole lot easier for them to understand it than when we throw numbers at them. You know, like Ken was talking about, oh, if I give you TPA, you got a 6% chance of a bleed, a 13% chance of getting better. You know, those types of things, it's hard for them to understand it. But if you actually give them a picture like this when you sit down to do your shared decision making, it makes it a whole lot easier for them. So the key points and recommendations, well, number one, pulmonary embolism is rare. If somebody's got a pulmonary embolism and as a cause of their syncope, you're going to recognize it. They're going to have other signs and symptoms of a pulmonary embolism. Syncope visits are on the rise, and syncope workups are on the rise, but it really doesn't change our outcomes with the patients. It's not clear that admitting people leads to better outcomes, although I think in my opinion, I think it does. I think it's a little bit better. EKG monitoring for high-risk patients or for people at risk is particularly important. You got to get it up to at least 12 to 24 hours. Clinical judgment pretty much trumps everything else. Look at any of the scoring systems, that seems to be the way to go. The Canadian Syncope Risk Score has high sensitivity and specificity in the Canadian cohort, but when they compared it to other cohorts, it didn't seem to work as well. And that is where we stand right now with syncope. Don't worry about PEs, worry about arrhythmias do occur, they tend to be rare, but they're the things that's going to cause a problem, and that's the reason to bring people into the hospital. And we have a couple minutes for questions. No? All right, so you guys are all comfortable with syncope. I don't know what the hell to do with it, but you guys are comfortable with it. All right, where is Raman? Is Raman out there?
He's on his way.
He said, oh, stall? Got it.
All right,
Nobody has an interesting syncope story.
So if I use the CAD score, you got it.
Right.
I know it's great, but
Can,
what am I anticoagulants? No, that's
well, no, the CHAD score, you're right, is to anticoagulate or not. But what they're saying is, if you use the CHAD score and it says, oh, you're supposed to anticoagulate, you're not supposed to anticoagulate the syncope patient. For God's sake, they just hit their head and they're going to bleed in it. It's like, yeah, no, that's not a good idea. No, it says that if it's positive for anticoagulation, it's positive that something bad happened to them and they should stay in the hospital. And really what the CHAD VAS score is it's a marker for atrial fibrillation. And we've all known a lot of these people who passed out just went into AFib, and that's what caused them to pass out. We actually had a guy, young guy has a syncopal episode. Medics get there, he's in AFib. He has a seizure with it, but it's probably one of those just kind of shaky little things when people syncopize. So they get there, and he's in AFib. They give him some cardiozen. They bring him to the hospital. And he's awake and alert now, and he's in AFib. And we said, well, Jesus, if this is new onset, we can shock you and put you back in sinus rhythm. We'll send you home. But he didn't know when it started. But he had a Fitbit on, and his Fitbit was hooked up to his smartphone. And so the advanced practice nurse who was doing his admission noticed the Fitbit. And she said, do you have it hooked up to your phone? He said, yeah. So she gets his phone, goes into it, and looks at it, and he's in, we presume, sinus rhythm. His heart rate's 70. All of a sudden, it jumps up to 180 at exactly the time he passes out. The medics get there, give him cardiozen. His heart rate comes down to 90. Cardiozen wears off, goes back up. So it's monitoring perfectly fine. So we said, okay, we know you just went into the AFib. Shock him, put him back in sinus rhythm. Cardiology talks to him. Yeah, we're not going to anticoagulate you just yet. This is your first episode, and everything else. Goes home and gets monitored and whatnot. So, it is interesting. So whenever I see these people with syncope and whatnot, I do look for either a smartwatch or a Fitbit or something like that to see if it's worked out. And the other thing is bradycardias. There are people who also, since we're just stalling for time, cardiac arrest. What time did grandma have the cardiac arrest? Oh, it must have just been 20 minutes ago. And grandmom's got a smartwatch or a Fitbit, and they look at it, it's like, grandmom stopped moving at 10 o'clock yesterday. I don't think she just, had her cardiac arrest at this time. You might not see the heart rate, but the steps just go away. It's like, yeah, she walked, oh, she stopped, and that's it. So, yeah, that sometimes you can look at that as well.